Inaugural lectures, really, they're our opportunity to recognise and to celebrate the work of our new professors. And I'm really delighted and I feel privileged to be able to welcome Professor Tom Fletcher to deliver his inaugural lecture today. Tom is a professor of emerging and high consequence infectious disease, and he's the director of the Global Health Trials Unit, who are all here, dressed up smartly, because he made them. He's a consultant at the infectious diseases and general internal medicine at the Liverpool University Hospitals Trust. And his research focuses on the clinical management of emerging and high consequence infections. So we're talking about Ebola, Marburg, Lassa fever, Congo-Crimean hemorrhagic fever, all the scary ones you hear about on the news. And before joining the School of Tropical Medicine, he served for over 20 years in the British Army, leading medical research and outbreak response, deployments across Africa, the Middle East, Asia. And his work bridges like the clinical care, the research and global health security right across that pipeline. And to me, Tom, you're someone who lives LSTM's vision and mission of reaching the poorest and most disadvantaged populations with our research and our education, making it count for those populations. And it's been really impressive to watch his laser focus on advancing equitable access to life-saving medication, to patients affected by those most dangerous pathogens, and to improve the care and to reduce the avoidable and the unfair differences in the outcomes. So depending on who you are, you might have a better outcome from a high consequence infectious disease. And I think the number of you here and the number of people online is a testament to Tom, who I've known since he was a trainee doctor in infectious diseases. I have to say, it's always a great pleasure to watch a highly competent person at work, especially in the current global climate. And in Tom's case, I know his patients and his teams find his competence very reassuring and an important aspect of his leadership. And when he was a registrar, I loved being on call the weekend when Tom was on for the weekend, because I'd be like, oh, as a consultant, I forgot an excellent registrar, and I'm sure Bertie would say the same, and David and others. And wind forward some years, we're now consultants together, and Tom and I once looked after the same patient. He had a severe respiratory infection, and on recovery, he sent us each a thank you card. And they must have come out of a stack because they were exactly the same card, same handwriting, same envelopes, and they arrived on the same day onto the same desk. And so we're opening them, and I thought they'd be identical on the inside, like they were on the outside. But on the inside, mine was you were so empathic when I thought I was dying. Tom's was you were so competent, I felt so safe, I knew exactly what to do. And I just wish I'd taken pictures of both of them so I could put it up on the screen now, because I think he had us quite nailed. Tom really loves solving things. In June 2024, I was inadvertently caught up in some Gen Z protests in Nairobi, and police were cracking down on demonstrators. And I had a Teams meeting with Tom. And he's like, oh, I've got mates in Nairobi. I think they could fly in a helicopter over the roadblock and sort you out. So big relief, as you can imagine. Tom's got my back. So I thought, if you're listening online, little tip while you're there, just fly in helicopters, yeah? But it's a testament of when there is danger, Tom goes towards it while other people are running away from it. And on his way, he kind of scoops up the other people that are running in the same direction, organises them, gets some solutions going, even before they've reached the place. He's not afraid to get stuck in, and he's not afraid to role model by doing it. And I think you'll hear a bit more about that. And I'm sure it's those qualities that got him awarded the MBE in 2016, which, was a source of great pride to everybody who knows him. Sometimes, though, I think it is a bit of an itch he has. That desire to help people, it bothers him when there's an outbreak and he has to sort of scratch the itch. And it's one that I'm not sure Claire and the girls always thank you for having, although I think the patients and your teams do. But I do want to pay some tribute to them as well today. Before I hand over to Tom, there were some little housekeeping things to cover. For those of you in the room, we're not expecting a fire alarm. So if there is an alarm, please follow the directions given by my colleagues who will be making it clear where to go. There are toilets available on this floor, through here and on the right, just past the little kitchen. And is that the last housekeeping thing? No, without further delay, let's welcome Tom.
Thanks very much, Miriam. You probably killed my first 5 slides, but that was incredibly generous. Thank you, everybody, for coming, and also thank you to everybody who's actually messaged me shortly to say they couldn't come. You know, completely unnecessary, but thank you all the same. This isn't really a talk about pathogens, I guess. It's not a Tom Fletcher, this is your life talk either, if that's what you're expecting. And it's not really going to be particularly heavy on the science. So it's really about working with high consequence pathogens, and that means, as you heard, Ebola, Crimean Congo hemorrhagic fever, and most recently COVID at one time point. And I guess what I'm aiming to do in this next sort of 45 minutes is to talk about, you know, when uncertainty is high and the consequences of failure are real, and what you do with that. My journey in these pathogens has taken place in a range of different settings, whether that's clinical training here in Liverpool, military service, as you heard, or really outbreak response in fragile health systems, and also, of course, working with global partners such as WHO. And I guess when I think about this, and this is a period to reflect, I think, as I put together this talk, probably what links that all together really is a willingness to try and drive change, to accept a degree of risk, to challenge established practice, and I guess to a degree to push the boundaries, try and improve care and outcomes. I think it's probably fair to say that's landed me in hot water a number of times, both with the military and in other places, and I'll try and highlight some of those times as we go through. And apologies to start, I'm going to start with a couple of apologies. So 2 brief ones. The first thing is I often speak too quickly. So that's often when I get a bit excited or enthusiastic, as I might do now, so I'll try not to do that. And secondly, if I don't mention some of the work that people in the room that we've done together. Some years ago, I wrote out a list listing all the projects I was currently involved with. It's genuinely a terrifying experience, which I will never repeat. So as we go forward, what I want today is a reflection of collective work. So it's a shared effort that I'm talking about here. It's not really about me, it's about many collaborations, and really far more than I could do justice with in the set of slides that we're going to talk about today. I should probably also apologise for using the word journey in the title, right? I resisted it for a while, but it eventually beat me, and it's probably the best of a number of bad options. But really what I want to talk about is a transition from reacting to outbreaks to really building the conditions for us to respond better, earlier and more equitably, and really about the academic environment that is required to make that possible. So I really want to reflect on what's worked, kind of what has not worked, and potentially what we should be building next. So obviously we had to have a bit of a structure for this 45 minutes, and so what I thought I would frame this around is why this group of infections, the high consequence group, those terrifying viral hemorrhagic fevers that terrify patients and healthcare workers alike, why that potentially needs a different type of academic. People often know that I have this military background, so I thought it would be an opportunity to think about what that has taught me in terms of skills under pressure that aids this work. Talk a little about those early experiences that we had in Ebola and CCHF and through COVID, and then of course look forward to how we're collectively within the group and the institution trying to build an environment for success around these group of infections. And then I want to leave you with this sort of thing at the end, which is really about preparedness being an academic value, and actually as an institution something that we should think about at all times. Most people will know me, and certainly my group know me well for this. I love an inspirational quote, okay? They feature in group meetings on slides. Now this one I got from Sir Mike Jacobs. So at the time, Mike was the head of the high-level isolation unit in the Royal Free. I was pretty likely to be a client of his at some point in terms of ending up in the Royal Free under his care, and he examined my PhD and became a close friend. But he gave me this sort of quote, which I really like. He told me he got it from a fortune cookie. It's on my wall. It's what our group talk about quite a lot. Particularly in this sort of world of high consequence pathogens, a lot of people talk a great game. They talk about what they're going to do. But as far as we're concerned, you can only really build a reputation on actually delivering, and really that means impactful change for the patients who are at the bottom of this. So, as you know already, in terms of that summary of me, I'm now this professor. It was about a year ago, almost today, that David phoned me up to say I got over the line. I'm a clinical academic, which I'll talk about the relevance and the importance of that. I have this military background. I'm working for WHO and with other partners. I've done a fair bit of outbreak response in a global setting. And when I think about this and I think about high consequence pathogens, when I think about a standard maybe professor talk, and you've seen many of these inaugural talks, they're pretty impressive and they're really varied about how people address this sort of this 45 minutes. But generally in academia, I think we value depth, certainty, and time, and people are real subject matter experts in their area. But probably in this group of high consequence pathogens, none of these are really offered. Now, whenever I see this picture, this is in Sierra Leone when I was the clinical lead for Save the Children, getting some patients with Ebola out of the ambulance to take them into the ETU. But whenever I think of that, I actually think of this, and it gives me flashbacks. So not in a dramatic sense, but just brief, intrusive moments of a pretty difficult time. I don't apologise for that, and I don't apologise for sort of saying this, or I'm about to talk about, or sharing this in this setting, because in reality, this is part of what Ebola outbreaks are like. So this is in Kenema in Sierra Leone, and there are occasions when frequently Ebola patients will be transported to Kenema, and you would open the back of the ambulance and find multiple patients inside who died en route. The more difficult part was to reach the patients that were alive underneath, often children. You had to remove those dead bodies so you can then get to the patients, then do your best to look after them. Now, I don't say this for shock, I don't say it for effect. I say it because that's the reality. And it's important that we don't really sanitize the work that this entails in this setting. So, of course, these experiences are profoundly difficult for everyone that's involved in it. But they're also, in a way, some of the most uplifting moments of my professional life. Mainly because we fought to save every life, every child, and every patient. And kind of in the midst of this extraordinary kind of suffering, you create bonds with colleagues and communities that are very hard to describe. And I'll talk about that a bit later, and impossible to forget, really, with our return to Daru most recently. And I guess this combination, I think, of difficulty and of meaning probably continues to shape what I think about outbreak response preparedness and kind of our responsibility to do this work properly and equitably. So, a lighter note. Yes, I am that idiot on the right. And yes, I'm actually top right, Cadet Sergeant Fletcher, kneeling down in black and white, which I think just evidences how old I really am, the black and white picture when I was a cadet. So, as Miriam mentioned, I spent over 20 years as a regular in the Army Medical Services, including 5 operational deployments. I joined as a cadet, received an Army Sixth Form scholarship, then went to Sandhurst after medical school. And I think you learn, when I was thinking about what I've learned during this time and what's helped me really, I think you learn that preparedness, leadership and judgment, I don't think, they're learned skills, they're not characteristics really. That's what the military tries to instill in you. Other key things that I think about in terms of outbreak response, that delayed decisions are still decisions. And fundamentally, as I talk through the slides, it's all about risk really. And the military tries to teach you that risk has to be assessed but not necessarily avoided. So when I look at this picture on the bottom right, that was in Basra in the air station there. Some of these deployments were quite punchy, okay? So there were periods where the bases that we were in were attacked on a daily basis, multiple times, often with indirect fire. And again, I don't say that for effect, but actually being in that environment teaches you things pretty quickly. So we spent a fair amount of time in Basra lying on the floor as rockets came in and were hitting that base. And you kind of learned that actually worrying excessively about things that you can't change or influence is rarely helpful. A lesson that probably is quite true and useful in academia too. So, after Sandhurst, I was posted to the Royal Welsh Regiment. Really excited about that. Had a few friends there. They had a good plan of stuff to do as their junior doctor. However, shortly afterwards, the appointments officer in the military phoned me up and said, there's been a change. You're now going to the Joint NBC Regiment. That means nuclear, biological and chemical. I replied sort of quite confidently, thank you, I'll stick with the Royal Welsh. I explained that NBC, as far as I could tell, stood for Nobody Cares. I wasn't a great fan of wearing that face welly. I was then gently reminded that I was in fact in the army and obviously pretty quickly went to the Joint NBC Regiment. The bonus was I was pulled out of the emergency department, sent for live agent training in Canada. At the time there was increasing concern about legacy use of chemical weapons in Iraq, and I spent a fair amount of time in the next year or so supporting operations that are detecting them and then destroying them. And the funny thing about that is I didn't want to do it, but it actually was an experience that turned out to be more important than I could have thought at the time. So some years later, I found myself working for WHO in Geneva, and after the events in Syria, was rapidly transitioned to work in the chemical team for 2 days a week. That grew into deployments into Turkey and into Beirut to train Syrian clinicians that we're bringing out to train them in chemical weapon defence, and then subsequently deploying after the biggest chemical weapons attack in Syria to do the public health investigation for WHO, including seeing patients in Turkey. Now, I didn't really set out to do any of that, really, but it taught me, I guess, something important, that being prepared to accept, uncomfortable roles, learning new skills, and I think operating at the edge of your comfort zone turns out to be exactly what enables you to succeed later. The other weird thing is it was probably the beginning of my slightly odd, fetish isn't the right word because that sounds a bit creepy, of enjoying wearing PPE in quite hot and dangerous environments. Okay? So I was wearing this. It also was my first introduction to WHO guidelines, which is painful for all of us who know we're involved in that process. So the other thing on these deployments that I learned was I was a physician there, so generally looking after people with heart attacks or diarrhea or vomiting or respiratory infections. But it's all really one team, and this was how often this hospital was described in Afghanistan in particular as the world's best trauma hospital that was frequently tested with severe trauma. And this was like the Formula One team it's described. So everybody in this team knew their role and was doing absolutely everything they could to save the life of the individual that came in, often minus one or more limbs. But being in the Defence Medical Services sort of instills something else, really. So it's this relentless pursuit of clinical excellence. So we say in the military that standard of care does not drop because the environment is difficult. And that excellence is to a degree non-negotiable, particularly when you're under pressure. And I guess for me, what I tried to do was translate that into Ebola outbreaks, so this experience. So where the challenge wasn't simply just to deliver that care, but to provide it really safely in that environment and drive that equitable access. And I guess if there's one group of patients in the world that have been excluded from access to life-saving care, it's generally the Ebola patient. The other thing that's really important that I remind myself of often is the military teaches us that teams, succeed or fail together. And I think that's probably a lesson in academia that we are still learning. So, local excellence and global readiness. This really captures, I guess, my influence in Liverpool. And I've been based here for almost 20 years now too, both in the Royal Liverpool Hospital, mainly not this one, but the old one, and LSTM in particular. And that's had quite an impact, I think, on my career. So I was really fortunate at the time when I joined to get incredible mentoring and guidance from people like Nick Beeching and David Lather in particular. They shaped not only what I worked on, but really how I thought about being a clinical academic, I guess. Nick in particular was instrumental in introducing me to colleagues in WHO who encouraged me to apply for this role there. And then David also told me quite early on that I wasn't really an academic. So that was probably meant quite kindly, but obviously it was like a red rag to a bull for me at that point. But it did make me think about what really defines and makes a clinical academic, or a good clinical academic. The conclusion I came to is quite simple, really, and it's really been reinforced here in Liverpool, is that the clinical part really matters. So being clinically current, being at the bedside, and looking after patients with severe infections isn't a distraction from global health work. It's actually what gives us credibility, particularly when I step into an outbreak setting, particularly and increasingly now in low and middle income settings. So I know that I've been very fortunate to train and now work alongside a remarkable set of clinicians in Liverpool who provide outstanding service to patients with infection, particularly in the Royal Liverpool. And this was key most recently actually in the Marburg outbreak in Miranda. The trust and effectiveness that we had there didn't really come from any titles, didn't come from any publications. It came from being clinically grounded and operationally credible. So people often ask me, in arduous fidelis means steadfast in adversity. It's the motto of the Royal Army Medical Corps. And people often ask me, so, right, your military career, how has that contributed to your academic career? I guess I often say it's not really content, but it's probably about how I sort of think, how I decide, and how I lead in that sort of pressurised environment. So Sandhurst in the military teaches you that you will almost never have complete information. And waiting for certainty, particularly in emergency response, is not really an option. So you learn to assess risk, make decisions early, and then revise them, importantly, as information comes in. And then fundamentally, in the military, you have to take responsibility for the consequences of those decisions. And I think that carries across into academia. It shapes how we design trials, how we protect teams working in this environment, and also, really importantly, how we insist that the evidence we generate is usable, ethical, and globally relevant. But it also teaches us collective responsibility. We know that in what we deliver, no mission is delivered by individuals alone. So teams succeed or fail together. And lastly, I think something that we neglect, and sometimes with WHO, they often ask me, will you go and teach, will you go and run a course on VHF preparedness overseas? And I sort of, I think it's 2 weeks going to do that, and it's difficult to go and do teaching. In the military, preparedness is sort of considered a moral obligation. You train relentlessly before deployment, because a failure to prepare is actually a leadership failure. So I guess that is now increasingly how I think about high consequence infections, to a degree academic training, and the responsibility that we have as institutions like LSTM to drive that care and be prepared for the next emergency. So what I want to talk about now is a little bit, I guess I'll go back a bit, from what that was in the military and the skills that maybe I got from that 20 years through to how that came to play in the Ebola outbreaks in the early days, and then CCHF, a bit less so on Lassa today, and then a bit about COVID-19 too. So I think the world's memory is pretty short in terms of pandemics. We've forgotten COVID and the impact that had in the world. We've moved on since then. We don't want to hear about the next virus coming around the corner to impact us. West Africa is largely almost forgotten a little bit too, and the outbreak that happened in 2013 to 15 was really unparalleled, the most complex and significant outbreak the world has ever seen. At times, these CDC predictions, people were worried that Liberia may collapse and fall as a country. The president of Sierra Leone asked the international community for help because he said, "My country is dying. Please come and help us in Sierra Leone." And so the region was paralysed and it needed a coordinated response. So I, at the time, had gone to work for the World Health Organization on this fellowship from the military for 18 months, which became almost 2 years, I guess, in total, with a simple mission, really. And that first year was all about building consensus, building partnerships across MSF and others, and member states, particularly Uganda, because we thought there would be the next outbreak, about how we would do better for the next outbreak of a filovirus, so particularly Ebola or Marburg. And if we are really honest with ourselves, the care up until this point for patients with Ebola had been so bad, it was unethical. So what we felt was it's too difficult. What people felt was it was too difficult. Everybody dies. The risk is too high to the provider. So what we'll do is do an isolate and die approach. We'll get them out of the community, stick them in an isolation centre, and tolerate 80% of them dying. So we'd worked in this year to build consensus that we could do better. We could challenge the status quo and actually change that case fatality risk before the outbreak occurred. And actually, about 2 or 3 weeks before I deployed out to Guinea and set up this treatment unit, Sylvie Briand, who's now the chief scientist at WHO, was my boss in the Department of Pandemic and Epidemic Diseases, and said, "Tom, what we fundamentally believe on is this concept of equity of access to life-saving care. And we know, as I mentioned before, Ebola patients struggle to get access to the most basic care." So I took this quote with me and thought that was useful as I headed off to Guinea to set up the first treatment centre in Conakry here. As I went out the door, my other boss, Nikki Shindu, my immediate boss, says, "Tom, whatever you do, don't mess this up." She actually used slightly stronger language, I would say, when she asked me to do that. But it was quite high pressure because WHO didn't have clinicians. So the clinical team, I was fairly terrified to discover when I arrived in headquarters, was an N of 2, now 3 with me, right? So one ICU physician, my boss, Nikki, and then me. And so we ended up working in this somewhat difficult environment. And this was in Donka, in the first treatment centre in Conakry, the first time Ebola had reached the capital city. At the time, there was one doctor there, Ibrahim Bar, who we're still in contact with and work with, who was the only doctor willing to go in and look after the 25 to 30 patients with Ebola there. There was no cleaners, there was no nurses, there was no nothing. All there was people doing their best to die. This is one of the few times in my career I ever put in place reverse triage, which is an uncomfortable thing to do. But what we did do was have a commitment to do better, to drive change, to ignore the status quo, to ignore this kind of thing where if you do what you always do, you'll get what you always get, which is 80% of people dying. And so despite that environment, as you can see in the top left, being really high risk to work in, we delivered high levels of care. All the patients on the bed, most of them didn't have beds because we didn't have beds, but they did all get IV fluids, electrolytes, antimalarials, antibiotics, etc. And then for the first time ever, we collected prospective good data. So let's actually collect data about what we're doing. Let's collect vitals and observations on these patients so we can understand what we're doing. And at the time when we were changing this up, we had a collection of the world's experts saying this is madness. You're all going to get infected. You're going to kill the patients with all this IV fluid you're giving them, and it's futile because they'll all die anyway. So they didn't. So that patient actually who you saw lying, the first one on the floor in the previous slide, was Abdullah on the right, and this is Bakri on the left. So they're the first survivors that came out of West Africa in the Ebola outbreak. People say, this is incredible. How have you got survivors out already? And it's pretty simple. So we drove care in this early treatment unit and dropped the case fatality rate to less than 40%. But it wasn't as great in Sierra Leone. So that was good work in Guinea. The world's expertise headed to Guinea at the beginning of the West Africa outbreak. no one came to Sierra Leone. So I went quite early, ended up in Kenema where we saw that difficult picture of the ambulance, and then had to travel to Daru most days because this was the epicenter of the outbreak in Sierra Leone. It's quite difficult to look after people who are gravely unwell in a tent in a field in the back of Daru. I would go there every day to support the clinical officer because his predecessor had died 3 weeks previously of Ebola and had stepped into his shoes to look after them, and then to take the sick patients back to Kenema to look after them. And I'll come back to Kenema a bit later and sort of Daru. But because we were collecting data, because the first time ever we took these devices into treatment units, we begged for them. They gave us iStats and we had a Piccolo, another device that can measure electrolytes, other key parameters in patients who are desperately sick. We had really small numbers of patients. People don't normally report a New England Journal paper with 40 patients, the first 40 patients managed in Guinea. The same we did in Sierra Leone subsequently. But probably the work that I'm not that most proud of is not these original articles in NGM, but it was the commentary articles that we wrote, the perspectives that a collection of us wrote, including you can see Shevin on there too, who's a colleague at LSTM, trying to advocate and drive for change around how we looked after patients with this disease. So after the president of Sierra Leone had said, look, my country is dying, please come and help, there was a big international community that came towards Sierra Leone to try and stop this outbreak and close it down. Some of that included a military response. So I went back in uniform the second time to Sierra Leone to set up a treatment unit for healthcare workers, because we were quite sure that if I was infected, I was going back to Geneva, I'd get access to intensive care support in Geneva, that was great in WHO. But for all the national staff, so all the doctors, nurses, hygienists who stepped forward to work in these big Ebola treatment units, and we had 700 or 800 beds open at one time in Sierra Leone for the outbreak. If they got sick, they weren't getting evacuated. So what we wanted to do was to create an HDU level treatment unit, the military were running to look after all the national staff who couldn't get flown out like we could. And so we did that, and that was very successful. I then got seconded to be, say, the children's lead, which is slightly unusual to be in charge of an NGO when you're in the military. And I also had one of my first interviews without coffee. So, in the military, I've had quite a few of these. It's probably part of the reason I decided it might be my time was up there, right? But Claire, I'm not sure who said, Claire Bebb, I was associate with the university, said, Tom, will you give an interview to Telegraph about Ebola and everything else? I sort of reluctantly, as I always do, said, all right, Claire, I'll do it. And so I fortunately got permission from the military to speak. I didn't always do that, but I did this time, and gave an interview. Now, I was slightly worried because Timo Dempsey, you'll know this, a great colleague from LSTM, he'd come out to Kenema to work in this terrible environment, was inside for God knows how many hours every day looking after patients. We know from the Royal his ward rounds would go on for days, and certainly that was the same in an Ebola treatment unit with Timo Dempsey, providing care to patients. But the government had said, we're not sure we're going to bring people back. So if you get infected in West Africa, actually you've made that decision to go there, maybe you have to stay and play and be looked after there. I didn't think that was great. And so I decided to speculate at the end of the interview about what Cobra may be discussing that day. Now, as a general, as a military sort of officer, speculating on what the Cobra meeting is going to be about isn't a great, but I decided I'd roll the dice. And so I said, well, of course, we have this air transport isolator that is designed. The Air Force are amazing at this. They bring back people with these high consequence pathogens. It's a remarkable capability. I then spent the next day after this RAF on standby to bring back infected Brits aboard, going from one interview without coffee to the next. In the military, that kind of means you don't get asked to sit down, certainly you don't get offered coffee, you just get a collection of bollockings over the course of the day. But I was kind of pleased because then it was tested a few weeks later when Will got infected, a nurse who just turned up to work in Kenema, and I spoke at like 2 a.m. to the Royal Free, then to the Foreign Secretary and others who said, yes, we'll go and get him. So I don't think it was my interview, but I was pleased. Now, this is a funny picture. I talk about this a little bit with my group, and this is actually crossing from Freetown over to Lungi Airport in Sierra Leone. And at the end of that first time I'd been out there, it was a really difficult time in Kenema. I'd had to leave because I was planning to leave because I'd been there for a few weeks, I was pretty tired, and I had a Welcome Trust interview 3 days later for my fellowship. But it was quite difficult to leave. And I remember explicitly standing at the back of the treatment unit or near the lab and saying, I'm struggling to leave here because no one's coming from WHO for a week or two. Khan's going to have to carry on his own, who was the local expert, and it'll be pretty difficult. And so I phoned up David, and I was like, David, look, it's quite difficult. I'm struggling to walk out the door and get in the WHO car to head back. And he was like, get in the car, you're tired, you need to come home. So I didn't like that advice, so I phoned Nick Beeching to get a second opinion, and he told me the same. So anyway, so I left probably a bit late because I then missed the ferry, missed the speedboat across the harbour. And so what do? You hire a dinghy with an outboard. Now, this isn't like a little stretch of water, it's like the sea. There's me, a fisherman, and a boat going across the across the sea. Obviously, we broke down as we got tangled in a fishing net in the middle. Then I just got dumped on a beach on the other end and hitchhiked to the airport. But just about made it in time. Yeah, Andy's horrified at this, particularly because he had to give me permission to go to Iraq recently. But that led to this. Actually, when I went for my CCHF Welcome Trust interview, it all went kind of well. There's a bit of shaking of hands. And on the train on the way back, I got a fever of 38.5. Myself spending 2 days in the Royal Liverpool. And I had norovirus from the children, thank you very much, not Ebola. But I thought it might have been quite uncomfortable for me of my fellowship to put all of the panel under contact tracing if I'd actually had Ebola from that. So CCHF is almost like the viral hemorrhagic fever that no one's heard of. But with work with Nick and David and partners in Turkey, we'd set up a fellowship as a PhD with Wellcome, trying to investigate this and set up what we thought would be biomarkers and planning for future clinical trials. This is actually a picture. You can see David, Nick, and actually Roger Hughes from UK State on a visit out to check on me because I was a bit Billy No Mates there on my own. For some reason, the only one who hasn't got a face shield on, I realised when I put that picture on. I'm not sure why. But actually doing that PhD in Turkey was quite challenging. I was in the epicentre in Tokat. People in Turkey often laugh at me, guys here from Turkey, when I say that I spent all these months in Tokat. It's a somewhat remote, sort of central place where no one speaks any English. And frankly, no one did speak English. But that's where I did my PhD. We did some nice sort of data reporting on this near-patient test to describe the bleeding problem. And then some more other research looking at what was the challenge to infection prevention and control for people working in this setting across Eurasia too. Nothing was straightforward in the PhD, as they rarely are, and we all know that. And I tell myself in my group that you learn more when it's difficult, right, and something doesn't go to plan. It wasn't super helpful after the attempted coup in Turkey, however, in 2016, when my two main supervisors from Turkey were arrested and put in prison for 9 months, and our sort of research team collapsed. So that was quite difficult and not really to be expected from Turkey. That led to some work with the UK Public Health Rapid Support Team, and I heard from Tom Edwards today that actually Julian is down there interviewing for that panel today, so fingers crossed LSTM will be a partner of the next iteration of the Public Health Rapid Support Team. But Tom Edwards and I in particular did some work with them looking at diagnostics, and then I did some work looking at where CCHF was in Africa. It's pretty common in Sudan, we found out. I then deployed for a big chick outbreak in Sudan too, which we thought may be CCHF, but was actually chikungunya. And then, of course, like everybody, I was impacted by the COVID pandemic. And when I think about this, I think about the WHO role with COVID, the NHS role that a lot of us did as clinical academics, and then what I consider my agile fellowship. So at the beginning of the outbreak, I think I saw the warning signs quite early to say this is quite bad. So in January, WHO said, will you come back and join the COVID task force from the clinical management point of view? And so I did. The other really key meeting that I remember having in January was with Lewis Cuevas and Emily Adams here, and we said, look, we think this is bad, we think it's coming around the corner. And they made a really brave decision at that time to reprofile the whole of the diagnostic group towards COVID. At the time, this was really early in the pandemic. They saw the warning signs and said, let's move everybody towards COVID and get ahead of the game. There was very few people, I think, in the whole pandemic who actually got ahead of COVID-19. We always felt like we were behind it, but they did because of that brave decision. And so I went back to WHO, and when I'm in WHO, I always get a bit frustrated because I don't like living in Geneva. I want to get out to the fields, and so they were probably getting frustrated with Billy and I being in Geneva too, so sent us to South Korea. So we went out to South Korea at the beginning of the outbreak to investigate and understand a bit more about the natural history of COVID-19 and try and take some innovation from what South Korea was doing. And they were delivering remarkable care. And one thing that we did, we translated rapidly into Liverpool. So Liverpool was early adopters of trying to look after people, particularly with enhanced respiratory support for COVID-19. We'd seen what was happening in Italy as it had marched across Europe. But some of that meant you had to have a safe environment in terms of the air where you deliver these high care interventions to patients. And so what we did was quite simple and was stolen from South Korea. So you knock a hole in the wall. Actually, in the old wall, that wasn't that hard. Most of the windows were broken anyway. And we bought industrial HEPA filter units, plugged them in, put these pressure changes over the walls, and then demonstrated we could rapidly, in a matter of hours or days, create multiple negative pressure rooms to give better respiratory care. Now, Becky is here, and obviously I wasn't going to mention this without you, Becky. Sorry, we'll get to the slide eventually. But Liverpool really led this, and really Becky led this. And it was a collective effort of the infectious diseases department in particular, with respiratory and with the intensive care team to deliver this high level of care to patients, which was not universal across the COVID outbreak whatsoever. But this saved huge numbers of lives. And I put at the bottom here this sort of YouTube video. Many of you might have seen this, and if you haven't, it's quite a funny video to watch. It's about the first follower leadership lessons from a dancing guy at a festival. And it's all about, if you have this innovative idea, and you're the first guy to stand up and dance at the festival. It's not really about you, it's about the first follower who comes and joins you and starts a movement. So anyway, I'd ask, it takes 2 to 3 minutes, which I didn't have in my talk today, so Google this and look it up. And then I think about my Agile fellowship. So many people, we all know as normal academics or as clinical academics, look at that time period for the fellowship, whether you might apply to a funder, to have the protected time to develop your clinical skills and your academic skills in line with where you're going to end up, hopefully leading a research group. So I didn't do this because I got it through Agile. So when I was at WHO, I took this phone call from Sekou, who sat just here, saying, I've got a bit of a crazy idea. Now, normally, when Sekou phones you up and says that, you worry slightly about what's going to come next, right? But it was about this crazy concept that he and colleagues had developed through the expertise in Liverpool, chatting to David Lalou too, about accelerating this drug development pathway. We haven't got time in an outbreak to go to conventional phase 1, 2, 3 trials. So let's get the most promising drugs. Let's pick the best ones and not the duds, and let's get them into patients quickly. And that became Agile, really, which is the UK's national early phase platform for the most exciting new antiviral drugs that came in, led by SAY and led by Liverpool. And my sort of privilege was really to be part of that and to learn really by osmosis from Richard Fitzgerald in particular and say about how we deliver early phase trials and take it directly into patients. It's a remarkable achievement really from the team at Liverpool. And what I want to talk about now is taking some of that knowledge forward to what we're doing now, what we hope to do going forward. So, sorry, I'm not good with the slides here. So the UMIT trial. So we took a lot of what we knew from those Agile methodology, what we've done in Agile in terms of accelerating drug development by dose escalating medications into patients directly to do this. Now, Ilkay and I delivered this over the last 2 years in Turkey. It was called UMIT because that means hope in Turkish. And a number of times we said there is a bloody good reason that nobody has done this before. Because what we were trying to do was accelerate these new drugs, this exciting new form of intravenous favipiravir, directly into patients and give it in combination with other drugs. What we had to do then was find a unit that could do it, which I'll show you in the next slide, and then bring patients from all over Turkey with confirmed CCHF, who are quite sick, would die if they didn't get great care, and deliver them brand new drugs in what's called the UMIT trial. So the results of this are about to come out, and the paper will go in soon. But every patient survived, which is great, 24 out of 24 that we treated. And we have some interesting signals, both from PK and from the virology. But what we really needed was that local leadership. And so we found effectively the Marsden, so the National Oncology Hospital for Turkey, said, an amazing leader of that hospital said, yes, I really like this idea. I know that traditionally we look after oncology patients, but we've got a phase 1 unit on the left. If you can bring the infection expertise, that would be Ilkay, we can do the rest around phase 1. And so we moved all these patients in. This to a couple here who travelled over 200 kilometres and were 2 patients who came into the trial. They're not your normal phase 1 patients, right? Normally people think phase 1, early use of drugs, we want young, fit, healthy people. These are not young, they're not particularly fit, and they've got a disease that's trying to kill them. It's also not super easy to work on a CL4 pathogen when you don't even have a CL3 lab. But with the right SOPs, we can collect the right samples, process them carefully, and then drive towards the endpoints that we need. So of course, after CCHF, we come back to Ebola again. And the next outbreak that occurred was in Uganda, so in Shevin Jacobs' neck of the woods really, and this was quite difficult. So you'd think that we would drive forward with the changes that we've learned from West Africa, the developments that have been made in the DRC and subsequent outbreaks. But we find ourselves at the back of the hospital in Mabende in a selection of tents in a waste ground with increasing patient counts again. But we also find that we don't have any proven therapeutics. So what we have is ceftriaxone, great, an antibacterial for a viral infection. We have artesunate at the top to treat people with co-infection with malaria. We have ORS and we have IV fluids, but no proven therapeutic. What we did have were some highly experimental monoclonal antibody therapies that were donated from the US. We thought they were good from the animal model. They'd been given to 6 adult patients before at full dose, and we were offered to trial these in this environment. Not the safest or the easiest place to do that first evaluation of brand new monoclonals, but probably based on the skills that I'd learned in Agile and how we deliver these drugs safely in phase 1 and dose escalate, we got on and did that. The other sad thing, it's a bit of a terrible picture on the right, is that we still don't have near patient diagnostics. So this is a PCR lab that's been set up in the Ebola treatment unit in Mabende near us. What we desperately need is near patient tests for Sudan virus disease. We can test people and treat them quickly. Again, as always, we had the similar people. So Billy, a great friend of mine from WHO, turned up, and a couple of other colleagues, one from Germany and one from the UK, Danny. And what we do is really work with those clinicians to help coordinate care and share our experience to try and keep them safe. There is one sort of somewhat terrifying story that relates to this. So for those that don't know, sometimes you can't get intravenous access. So the cornerstone of really treating patients with Ebola is fluid resuscitation, electrolyte replacement, and then giving other key medications. But you need a parenteral route, so you need a way to give them a drip. When patients are quite shut down or sick, it's quite hard sometimes to get that in. Before in Sierra Leone, I'd used interosseous guns a fair amount. So that's when you drill a needle into their tibia often or their humerus and you resuscitate them. Quite good for kids, quite difficult in adults. Every patient I did this in Sierra Leone was dying and unfortunately died that I put an interosseous gun into. But in Sudan and Uganda, towards the end, Danny and I, he just turned up to take over me from WHO, and we said, we'll go and do a ward round. Nikki, my boss, was there at the time because we sounded the alarm to say things are losing control, so please come and help. So she was there too. And so Danny and I were doing this ward round, and we found Nabuma. Nabuma was dead sick, gravely unwell. She was quite a big woman. All the nurses kept on saying, oh, she's so fat. And I was like, guys, like, she's desperately sick. Let's not fat shame. It was a compliment. I realised afterwards that they were impressed with how big Nabuma was, but she was dead sick. But because she was so big, we could not get the interosseous needle into her. So we asked for the gun. MSF brought one. We said, look, let's try and get it into Nabuma because she's desperately sick and we can't get IV access. She was encephalopathic, rolling around on the floor and dead sick. So Danny and I tried. We tried in a tibia. We tried in a humerus to get it in, but there was too much tissue to get through for the big needle to get into her bone. So we were there in our PPE on the floor reading the instruction manual going, apparently you can stick it in the ankle. I've never heard of it going in the ankle before, but we decided, let's give it a whirl, right? We've got nothing to lose. At that very moment, as we're drilling this into the ankle, obviously you normally wake up when someone gets into bone and you give them some fluid. My boss, Nikki, comes around. She's sort of standing in the doorway to see Danny and I scrabbling around the floor, drilling this into some angle. It's just this look of horror on her face, and she quickly moved on. The nice story is that it went in. She got 3 litres of fluid that day. We put another one into her other ankle the next day, and amazingly, despite having creatinine of 700, Nabuma survived and then essentially escaped and walked out. People sometimes ask me, but why do you do this? Why do you keep turning up for these high consequence or Ebola outbreaks? And this is really the simple reason. So it's for people like Boris and Rita in that bottom right picture. So they are the national staff, 2 doctors there who worked in Uganda, who will turn up and deliver care inside this high-risk red zone environment with minimal training. And our job is really simple. It's to try and keep them safe and create that environment for them to succeed. And that's why Billy, Chev and I and other colleagues will turn up every time. And then we move on, lastly, in this filovirus group, onto Marburg. And this was what I think was probably the next paradigm shift. So the shift that we led in West Africa, where we realised that you can halve the mortality rate by doing the simple things well, was really tested again. So Marburg was a complex outbreak in Kigali in Rwanda in 2024. So it happened in hospitals and nosocomial transmission. So 80% of the patients were largely ICU nurses and doctors who'd got infected in those waves of infection. So quite a difficult group to look after. But as many will know who worked in Rwanda, it's got quite a remarkable and resilient health system. And so they rebounded pretty quickly, commandeered a private hospital with an ICU, as per that bottom left picture, and we were able to offer exceptional levels of care to patients inside. Of course, all led and delivered by random physicians, with just Billy and I supporting them with technical expertise. One thing that I found challenging is this. So, we believe in doing clinical trials to demonstrate evidence about new therapeutics, of course. At the time, Oxford were here as a team setting up the clinical trial as we were working inside. And remdesivir was one of the arms of that. Remdesivir is a bit like an antiviral. It's been around for a long time. We've given it a lot during COVID. No one was sure how good it was. In one of the Ebola trials in the DRC, it looked like it wasn't as good as the monoclonals, so the monoclonals were licensed. The Ministry of Health in Rwanda said, look, we've seen the preclinical data, we've seen the animal data, and we've given remdesivir loads for COVID, so we're going to give it to every Marburg patient. Fine, that's your decision, of course, the Ministry of Health to give. So we supported that, delivered it to a lot of patients. The difference here is the patients, because they're all healthcare workers, they're all quarantined, turned up on day 1 and got remdesivir. So they got the antiviral exceptionally early. And every single patient after we turned up survived. So 50 out of 50 patients we looked after in this unit survived. So some deaths before that, you always get deaths, but then 100% survival. Now the clinical care was good. We had an ICU, which we used, but it wasn't that good. And so now I'm looking at this going 0 out of 50 deaths. The only real difference that we gave was remdesivir, and we gave it on day 1 or day 2. So that challenges what I think about clinical trials in this setting a little bit. Now to move on quickly, and I'll canter through these last few slides because of time a little bit. So what we're trying to do now within the group, I'm a bit allergic to this title Fletcher group, but I guess I used it, so So one of the big things that I drive for is what we call test and treat. So the real difference of viral hemorrhagic fevers is testing people really early, moving that testing from the hospital into the community, and then probably treating them really early with broad spectrum antivirals. That's the game changer that we're all striving for. And this is a crucial thing. So the DETECT study that's now being run by Anna is based on a lateral flow test that Kate developed during her PhD with the HPRU, a remarkable thing. And this is now going its final trial in Turkey this year, then will be licensed and approved, and the first lateral flow test out there really that's in widespread use, we hope, for a viral hemorrhagic fever. So an amazing thing. Based on that UMIT-1 trial that we talked about, we then got MRC Applied Global Health funding to run UMIT-2, which is the trial design on the top right. So that starts in May this year too, across multiple sites in Turkey with different drugs, a platform trial of antivirals. So we are moving forwards with these trials in CCHF. But we can't really just wait on that. We need monoclonals. That's the advanced program at the bottom. We have great monoclonals for CCHF. We just need to get them funded, taken through phase 1 and then into patients 2. Now, I always said, look, we do diagnostics, we do therapeutics in the group, we don't do vaccines. We don't do it, it's not our expertise. And then we came across this remarkable vaccine called the PROTECT CCHF study. This is the grant that's going to be happy very shortly, which is essentially a true One Health vaccine that's delivered not to humans, but delivered to animals, so to cattle, largely, and sheep and goats, that is anti-tick and anti-CCHF, and looks like it's going to be brilliant. So we are going to do that one. But what else are we going to talk about in terms of what else is the group doing? Because as we said, it's a collective effort. So I had to put a bacteria in here. I'm mainly a viral guy, as people know, but Steve would have shot me if I hadn't mentioned Brucella. And when we think about vulnerable populations that we serve in LSTM, Brucella is almost like a neglected tropical disease, I think, and it's really because nobody really owns the problem. It affects poor and rural communities, and they have little political influence, limited access to diagnostics, and minimal advocacy presence. And unlike TB, HIV, malaria, there is no real strong global activist or funding behind this disease, Brucella. It sits in this funding dead zone because people say it's a livestock disease that humans get. And then this other thing, it disables rather than kills. It doesn't cause big outbreaks or dramatic deaths like dengue or Ebola potentially, and it doesn't generate political urgency. Diagnostics are weak, so there's poor data, and treatment's long and toxic. And the treatment that we know about for vulnerable individuals, pregnant women, or of children is almost non-existent, and therefore there's no real incentive for pharma. So this line, I think, is important. It's one of the most common bacterial zoonosis, but one of the least visible. So this is the drive. The Bruce trial. Nick Beeching's been involved, a long-time lover of Brucella, and we're trying to drive and now get funded this adaptive large platform trial to try and do the first trials in this disease for over 30 years. Next, dengue. It's amazing, isn't it? We've all seen dengue be on fire across the world, particularly in South America. There are no licensed treatments for dengue. Increasing mortality is now occurring. We're not getting better at this. The population that are getting dengue have more comorbidities, more obesity, more type 2 diabetes, and they're having more severe disease. We know there's a vaccine out there, which is great and a big advance, but it's only got moderate efficacy. WHO has now recognised this, as have others. There's a bit of hope. So welcome on a discretionary of orders as funded Oxford to do the Den Host trial, which is great. Big like recovery trial, thousands of people randomised into pragmatic drugs. But what we really need is Agile Mark 2. What we really need is a trial working with partners in dengue endemic countries to look at the most promising new drugs, probably targeting endothelial dysfunction of the host as opposed to antivirals, which hopefully maybe Fibrin 2 trial or another that's in development. And then lastly, as I talk about this with the group, we focus a lot on therapeutics and diagnostics, but the only way that we can operate in this dangerous red zone environment is by keeping ourselves and the people that we work with safe. To do that, it's all about infection prevention control. The evidence base that informs the transmission around pathogens is incredibly weak. People don't do great studies to do it, apart from Susie. So this just highlights some of the remarkable work that she's done in the last few years, really, driving data that's gone to SAGE, this robust air sampling in hospitals, huge numbers, mpox sampling here in Sierra Leone, and then now moving into this high consequence group in terms of CCHF and Lassa that has been done this year too, to try and understand how these diseases transmit. She even, I think, bottom left, you can see a picture of a cow, a true One Health investigation of transmission, a cow with a coronavirus in the Imagine box. And hopefully this will lead to a discovery award that's going to go in at the end of this year. The other area, sometimes I think people look at what our group does and say, oh great, you just do trials for other people of their drugs. Where's your basic science? What are you doing? Now, I guess coming from my PhD and then all the way through to the work that Matt, Donald and Ilkay are doing now is trying to answer a really simple question. So with these viral hemorrhagic fevers, we don't understand why patients bleed. We've known about them for a long time, but we haven't done great research on them for a long time. So what we've been doing ever since now is work in these key diseases to try and understand what's the problem, and it seems to be a problem of platelets and platelet function. So now with this great new collaboration that we have with Reading and other partners, we're going to drive a Discovery Award this year to try and answer this question. I think it's perfect for it after Wellcome's recent visit to here. So as many of you will know, we've also got these collaborations with the Kingdom of Saudi Arabia around setting up a lab to really accelerate that work we've done with CCHF lateral flow tests into a range of other zoonotic diseases. So this is super exciting for us. Has been awarded, but not contracted, hopefully soon. Then another grant that we hope is coming is called the SAND grant, which is working again with the Kingdom of Saudi Arabia to look at a range of diagnostics and development of lateral flow tests, particularly for MERS-CoV and Rift Valley fever. Lastly, I guess, when I look at this, I think with my clinical academic hat, and I have this other job where for the Special Advisory Committee in the UK for infection training, I'm the academic lead. And this report on the bottom left is pretty sobering. It's really demonstrating that clinical academic training in the UK is falling off a cliff. There's more clinical academics over 65 than there are under the age of 35, which is very terrifying, isn't it? And I think we there as an institution have to grab hold of this, and this has been discussed many times within LSTM, and think about how can we create the environment for that role for clinical academics. And I think some of that is we have to recognise it's team science, we recognise there's a role for leadership, we recognise some of that should be focused on operational delivery to improve and impact on patients. A lot of people have different definitions about what innovation means. Mine is pretty simple. It's about increased capability in the hands of the end user. That's really what innovation means in research for me. Giving increased capability, which for me is often that frontline clinician. So I'm pretty fortunate to lead sort of like a mugshot of all the people in the group here, a pretty large group of people, including Nick, who actually I spoke to most recently this morning, who still gives me that strategic advice in the top left. And we have honorary appointments with UKHSA 2 and a sort of terrifying number of PhD students I'm not allowed to take on anymore. But they're all pretty remarkable individuals, and a number of them here are a three-line whip to be here today, right? The other job that Miriam mentioned that I have is Director of the Global Health Trials Unit. And I sort of consider myself in the last 2 years being really extraordinarily fortunate to work with this sort of remarkable set of people that are shown here, really. I generally consider the GHQ to be like a high-performance team, in many ways similar to what I used to see in the military. So a sort of a clear purpose, a mutual trust, and really a shared understanding that what we do hopefully translates into real-world benefit as a trials unit. And I think this team is really absolutely essential to what LSTM is all about. Not just delivering excellent research, but ensuring that research leads to practical, deployable, translational outcomes that really align with the mission that we have in LSTM. I think the other thing that's clear to me also is, whilst I might be the director, I think most people know that Charlotte is very much in charge of this unit too. And appointing her probably is, without question, the best appointment I'll make in my career. So lastly, I'm just coming to a finish now, really. And this is really about this idea of moving from outbreak response through to preparedness and really doing this work in peacetime so that we're ready. We know that the next infection, the next outbreak will require speed, will require trust and a degree of integrated leadership. And I think why is LSTM really well placed to do this and respond to the next outbreak? Fundamentally, number one, I think, is our embedded global partnerships and that strategy that we have and the way that we behave. We've obviously got a really strong track record in applied science, which positions us ideally to do this. But I think the last bit is probably important, is that we have this sort of institutional courage to work where the evidence is incomplete. But fundamentally, if we want academics to step forward into crises, I think institutions must step forward with them. I'm going to finish on two little proud things, or three things. So firstly, Romeo is a PhD student who graduated last time in the graduation we had in December. Now, Romeo is a really unusual dude, right? So he's a soldier in the military, and he is the first non-commissioned officer, the first soldier ever in the UK military to get a PhD. So a pretty remarkable undertaking that he drove on his own through his career, and actually during his time here with a lot of support from Nick Beeching too. Now, if you remember, I mentioned Daru. Daru was the epicenter of the Ebola outbreak in Sierra Leone. I ended up in that first time I went to Sierra Leone looking after a lot of the Paramount Chief's family and a lot of other people in this village, because that's where Ebola came into Sierra Leone. We visited there in September last year, and it was great to hear the testimony, great to meet some of the people who sort of recognised me and probably my bald head from looking after them before, and that they'd obviously survived and gone on and really strengthened the community in the way they respond to outbreaks, and were kind enough to make me a chief of this village right before we left at the end too, which was kind. Now, I couldn't really talk about anything that I've talked about today really without really acknowledging the role that I guess my family has played in enabling it really. you've probably seen it already, it's fairly obvious, this work has a cost, right? It's rarely give much notice, and I've often left at really short notice, already spent months overseas. That's meant missing birthdays, I guess first Christmases, but probably more difficult actually is not being present for the routine things, the everyday things that matter just as much, right? And often these things collide, don't they? So I remember one year, when we were doing a trial and we had an outbreak, I was away for 7 months, and that's not easy for anyone, and not something I guess I'd take lightly. But what's made it pretty possible is that extraordinary support, patience, and understanding at home. And I guess without that, none of what I've described here would have happened. I'm also, I guess, a bit conscious where your values come from. And this is not going to turn into like an Oscars thank you speech, like Refuge Order, right? But I guess my mother was a paediatric nurse who worked for years, actually, in rural Malaysia, looking after sick children there. And my father was a light rail engineer who loved going to work every single day, and I try and take that forward myself. And then lastly, I was going to finish with a quote and a couple of sentences. So many people will know the stop saying, which is a famous African saying, which is, you can all read for yourself, which is fairly clear. I'm fortunate on the left to work with remarkable people like Shevin and LSTM, and much of what we've delivered and done has been as this team of like-minded individuals through WHO. My first OJAM is Professor Hakan on the right, who supported me and trained me while I was in Turkey looking after CCHF, so I'll always remember him. But then it really comes back to the patients. So in the middle is Rachel and Matthew, and this is in Uganda in the Sudan virus disease outbreak. So we found Rachel gravely unwell in a suspected tent with Ebola, collapsed on the floor, unrecordable blood pressure, and again a nasty acute kidney injury with a creatinine of 600 plus. So we took her back, resuscitated her. She got better, actually relatively quickly, with that basic supportive care and intervening. When we took her back, we found that she had a 7-month-old Matthew. She was breastfeeding. Now, generally, if you're an infant, you do really badly with Ebola infection, 90+% mortality for many different reasons. And so we were fairly worried about Matthew, and not surprisingly, he then tested positive for Ebola about a day later. But we had access to that monoclonal, that MBP134, and we said, with chatting to Rachel and getting informed consent, let's give him a whirl. So again, we placed another interosseous into his tibia, gave him a tiny amount, because that's all he needed, the first child ever to receive the drug, and he cleared the virus 2 days later. So my story with this really is that for patients like Rachel, really good, enhanced supportive care will save their life, you've just got to do it. But actually with vulnerable populations or high-risk patients like Matthew, we need better tools, we need better therapeutics, such as that monoclonal that undoubtedly worked. And lastly, I'm going to finish with one last quote, which is in Turkish at the bottom, which is essentially our motto, is patients don't have time to wait. So we talk about all these things that we want to do, but all the time there are patients with LASA, with CCHF, who need better tools and better diagnostics. Okay, I'm done, thank you.
Very much, Tom, for an insightful lecture that was reflective and clinically grounded, operationally and academically relevant. We do have some time for questions, and what we'll do is we'll take some from the room and some from online. If you're in the room and you want to ask a question, raise your hand and then someone will come to you with a microphone. If you're online, drop the question in the chat and Niall and I will coordinate over looking out for it, and we'll do our best to read out as many as possible of those. And Tom, if you maybe want to come here, I think that's what we're meant to do. Is that right, Sarah?
Fireside chat at the front.
Yeah, I think we're supposed to sit here, like
not left much
it's
time
in
for
conversation. And he's run over, so there's not that much time.
I didn't think they'd cut me dead at 45.
I mean, I'll start with one. You talked about early community testing and getting those out. What have you found any barriers to that when you go out into communities?
I'm feeling a bit uncomfortable sat here. To be honest, it hasn't really been done. So that's the problem. So that we know that we need to, I call it shifting the centre of gravity from those reference laboratories into the community, driving towards test and treat. So that we know, even doing the research in those communities is obviously challenging, but it all depends on obviously community engagement in advance of doing the trials of the diagnostics. But in an outbreak setting, particularly for viral virus, it's really difficult because there's so much fear in those communities. Some of those communities are often remote from government, don't particularly like government or authority, and then you're turning up in the fear of an outbreak and trying to instill something new. So it is really difficult. I mean, in Daru, that village that we sort of showed, the way that we were able to go and actually hunt for cases in that village at the very beginning was by engaging with those community leaders, so the religious leaders and the paramount chiefs and others who were trusted, and then could sort of bridge that acceptance into the village. But coming back to the first point, undoubtedly the only way we get from 40% from Ebola down to much less is taking those tests into the community, testing people early, and then immediately putting them onto appropriate antivirals.
So the trust part of it is going to be really important.
And as you know, WHO often deploys anthropologists in the beginning of an outbreak, trying to understand those communities and how we should best interact with them. But it's just very difficult to do in the context of an outbreak and a fear and death that's going on around there, to try and really understand and work with those communities. So it is crucial.
Yeah, PG, and then...
Thanks, Tom. That was fantastic. When people have got a mortality of 40, 60%, doctors will throw anything at them. That we saw it with SARS, we saw it with amiodarone with Ebola. Have you been able to stop that? Will that and those drugs may increase the risk of death. Have you been able to? Is there a way of stopping that happening in the future?
Yeah, I mean, I think there's a number of difficult points there, Paul, which I think are relevant. There is, of course, a willingness, and even people question the ethics of randomising patients. You know, when you've got a 60 to 80% mortality, is it ethical to randomise them to standard of care? I generally don't have too much of a problem with that, because standard of care is what 90% of people are getting. Otherwise, you run the risk of just giving everybody drugs with no clear evidence base. So I guess before Rwanda, I was probably quite as aligned to the big platform trials that WHO have set up around filoviruses that have that peacetime prioritisation with countries to agree what do we think are the most promising drugs, what do we think is the appropriate ethical trial to put in place in the next outbreak. And that's what often Oxford and partners help deliver with countries, these platform trials. I then changed my mind. Now, we talked about this, actually, Paul and I did, after I got back from Marburg, because the country, as is obviously their right, decided we believe in remdesivir, we believe the in vitro data, and we think we've got plenty of this stock in the country, let's give it to every single patient. It's not my view in WHO that has a role there to say whether that's right or wrong. But fundamentally, the outcomes that we saw there with every single patient surviving, and the only thing I can really put it down to is getting that antiviral exceptionally early in disease course on day 1 or day 2 probably made the difference. Now, of course, that's not randomised in a clinical trial, and direct to the trials unit, I shouldn't support that. But as the pragmatist looking after patients, and the decision that I would want, if I had it or my relative had it, it becomes difficult.
Yeah, it's a big obvious effect, isn't it?
Pretty big, yeah.
Yeah, I have question, but not related anything about the clinic. So you have experience to handle outbreak as a military, as an army, and also as, I would say, civilian. Are there any differences when you handle outbreak as a military officer and as civilian, and which one is much easier to, to handle?
Okay, super. That's not an easy question, but thank you. Yes. So look, generally, for most times, I have more of a public health view that generally we don't want to see the military intervening in public health outbreaks. We want the Ministry of Health, we want local clinicians to drive that and look after that care. Often when you get a country that's under significant threat because of the scale of the outbreak, it's every resource is enabled. And obviously the militaries in many of these countries, like Uganda and other places, are trusted, and they have good medical services, they have a degree of discipline, a workforce can then rapidly be deployed to do it, and to a degree are, don't volunteer, they're told, aren't they? They go and work there, and that's what they do. So generally I've had this resistance to using military in outbreaks, but I think, particularly in Sierra Leone, where the military deployed, at the time, I was like, I'm not too sure about sending all of the UK Defence Medical Services out there when we've got no experience apart from me with looking after patients with Ebola. And I was 100% wrong in my assessment at that time. Because what the military did was they were very good at training. So the military is really good at training people. So we deployed a whole squadron of medics out from the army who set up the WHO training package. And what they're very good is at putting people through a training pipeline. This is what you need to learn. This is how we'll deliver it. We'll coordinate it. We'll do it very well with technical assistance from WHO. So that was a remarkable thing. The other thing they did that was very good was bring communications and leadership and organisation. So across Sierra Leone, every district then had a couple of military officers from Sierra Leone, from the UK, who went to coordinate the emergency response and how that happened. And again, that's something they're generally quite good at. I was a bit sceptical again about putting these young junior officers out into the field to coordinate response to Sierra Leoneans, but it worked incredibly well. So I think there's definitely a role for it, but it's just, it's complex in the humanitarian space, as you know, and some NGO partners are not too happy working with the military. I think a lot of that is more mature and sensible now, and it's not how it used to be. But there is cautions involved in that humanitarian space.
We've got some online questions, if that's okay.
Online from Barry Atkinson.
Yeah.
Needed in order to speed up detection and response to outbreak. I would guess treatment in country is easier when numbers are low.
Yeah, so it's all about a robust surveillance system with an alert system. And often, we call the clinicians like us who are working in the facilities the canary in the gold mine. So those are the ones that we have to empower to detect that first case. Like in Kigali in Rwanda, an ICU physician saying, this doesn't look like the bleeding that we see in malaria for someone who's sick here. Is this a filovirus or something else? So we need to enable that surveillance system. You then have to have the response system so that when they call the alert and say, I think I've got something unusual here, have I got an alert case for a VHF, that something actually happens. A, there's testing, A, there's results, and there's a response to coordinate that. But fundamentally, when you look at the WHO R&D task force for all of these, right? They say, what do we need? What tools do we need for Lassa, CCHF, Ebola, Mpox, anything? It's three things. It's vaccines, obviously, all we hear about is vaccines. But what we desperately need is diagnostics. We need better treatments. But what we need, as we were saying before, is to shift those diagnostics and treatments out of treatment centres and into communities and get to patients much, much sooner. So that's why we have this, obviously, this emphasis in LSTM that we've had for a long time about decentralising lab testing and getting near-patient diagnostics out to the point of need and the point of care where we need them. And that's 100% true. Thanks, Barry.
One more online before we go back to the room, sorry. Do you think the civilian response team should get a similar type of training as military preparation?
Yes, to a degree. So I think it actually happened in the West African Ebola outbreak. So the military has a very good training establishment up in York where we validate our field hospitals before they go out the door. And that was re-rolled into an Ebola treatment unit where they can film everything, test people through different scenarios. And so the UK foreign medical teams that were going out to work in Sierra Leone were routed through there to have a set of military training. And as you'll know that on the back of the outbreak, UK Med is now an incredible organisation that's been set up by the UK, by the government, that's responded to many outbreaks. And they have a sort of a curriculum and a structure for people joining UK Med that resembles quite a lot of the skills that people get at the beginning of their military training to allow them to be resilient, robust, to go and operate in sort of outbreak or disaster zones with UK Med. So I think that has probably happened already, I would argue.
One more question, Bertie. Was that your hand up? Were you pointing at somebody? Oh, yeah.
Hi, thanks. Yeah, thank you very much for the talk. I really enjoyed it. I just wanted to ask for a postgraduate student who's really interested in outbreak control, especially coming from the public health side, what recommendations would you have for them to gain any training or routes to be able to be out on the field with yourself, people like yourself, involved in being able to control outbreaks and help those vulnerable populations?
Yeah, that's great. It's a really good question. It's one I get asked quite a lot after the diploma or the master's courses. On another side, I'll put one part to the side of it. So for the clinical role that we do, and often people come to me who are clinicians on the team and say, it's tremendous, can we go and work in the next outbreak? That's quite difficult to get into because you have to be highly trained in your specialty, first of all, whether that be emergency medicine, ITU or infectious disease. And so you have to be good at your specialty first, and then bring that expertise of working in often a low resource setting, and then try and put those together with the technical knowledge, and often go on your first deployment, which is normally with an NGO like MSF or ELIMA or somebody else to go and work in the field with them in outbreak response and learn by experience of doing it. And then after that, if people keep doing it, then they get better and better at it. Many people, unfortunately, only want to do it once, right? So they've seen it, they've seen the horror of it, and actually, thanks very much. I did it. I've got that tick, but I don't want to do it the second, the third, the fourth time. Thank you. And that's entirely understandable, of course. From your question about the public health side, again, I think I'm not a public health physician, I should caveat, I guess, is that it's about being good at the core principles of public health training with advanced training too. And then it's all about opportunity, isn't it? So going to work for an international organisation, getting experience working in the field when an outbreak comes along gives you some of those core skills. Then it's opportunities to work with organisations like WHO. They have various schemes. The WHO website, obviously they've taken a big salary and funding cut recently in WHO, so a lot of people don't have jobs there anymore. But when they hopefully become available again, often out in the country offices, they will have jobs for epidemiology officers or other officers, and working in that world just gets you experience to it.
Thank you.
It's a small minority of people that actually want to do it, so tremendous.
Thank you very much, everyone, and thank you, Tom. This lecture is part of a regular series of inaugural lectures, and our next one It's being held on the 11th of February and will be delivered by Professor Joe Raven. If you're interested about finding out a little bit more about the whole series and what we've got planned, I think there's going to be a website on here somewhere. Check our website, our brilliant LSTM website. I'd like to just invite you all now to come and join us for a drink outside, talk to each other and talk to Tom and chat with people and other guests. Thank you so much for coming.